Hi, I'm Dr. Jared Gardner, and I have a very special guest here today, Dr. Andrew Rosenberg, who is a world-famous bone pathologist, and he was visiting our institution.
And that's bullshit.
He's visiting our institution to give some lectures today and tomorrow, and he kindly agreed to go over normal bone histology and development and reactive changes, a few other things, and we have a few residents, fellows, and even a orthopedic oncologist here at the table with us, so we're all looking at the scope together and learning from Dr. Rosenberg. So, teach us about bone and cartilage, please.
Welcome, everybody. I'm starting out showing what Jared used to be so you can understand how he has become what he is. And so I'm going to take everybody from the very beginning with regards to the formation of the skeleton. And I want everyone to be aware that what my goal is today is to talk about growth and development of bone tissue, the skeletal system, and how the individual cells within bone tissue work together to produce a functional, successful, essential organ system, and how those cells play a role in different types of disease processes. The skeletal system first begins to form several days after conception, where the genes that hold the blueprint for the skeleton, which is composed of how many bones in the body, Jared?
Oh, 202, 206.
I won't ask our orthopedic surgeon because I know he knows.
I don't remember.
206 bones in the body. Many of the bones are bilateral and symmetrical, so that blueprint is very complex, and that genetic information is housed in the homeobox genes. So several days after birth, those genes become activated, expressed, that result in the formation of mesenchymal stem cells that have the capacity to migrate to the location at the site of future bone formation. And those mesenchymal cells form tight hypercellular collections known as mesenchymal condensations of the stem cells at the site of the future bone. In all humans, roughly at around week 6 of gestation, genes in those mesenchymal condensations, the genes that are expressed, change and begin to produce those substances and tissues that we have designated as hyaline cartilage. So the vast majority of the bones first form from a model of hyaline cartilage, and that the name for that model is known as the cartilage analoga. And we are looking at a distal extremity in which all the bones, we're looking at metatarsals, are composed purely or almost purely of cartilage, and this is the cartilage analoga. So at the time of this formation, they lack a medullary cavity, and they are composed of a solid rod of cartilage. Around week 7 of gestation, there are changes both within the chondrocytes and the surrounding connective tissues of those cartilage, quotes, bones that occur that initiates the very earliest stages of bone formation. So week 6, cartilage formation begins. Week 7, bone formation begins. And we're looking at these metatarsals. If you look along the length of them, should I use the...
Oh yeah, you can use the pointer right here. I think the bottom one may be the one that's turned on.
Here it is.
That's perfect.
When we look in the middle of the shaft of this metatarsal, we can see that there's a difference. And the difference is the matrix is darker. There are more clear spaces, and those clear spaces represent chondrocytes that have enlarged in size. And these chondrocytes are analogous to what we see in a growth plate known as the zone of hypertrophy. What we will look at first are the tissues immediately surrounding those areas in which the chondrocytes have become enlarged. We have this metatarsal composed of hyaline cartilage. The cellular sheath around the cartilage is known as the perichondrium. At the site of the beginning of bone formation, the primary center of ossification, we see a change in the cells that are located in the perichondrium. Here, these cells will become chondrocytes. Notice overlying the areas where the cartilage is enlarged, we have a different type of cell. We have a cell that's polyhedral, a cell that has more eosinophilic cytoplasm, that is eccentric with a perinuclear huff, and they overlie a very thin layer of dense eosinophilic tissue. And this is the very earliest stages of bone formation.
Cool.
This is the primary center of ossification. So in all humans, and we're trying to understand the molecular genetics of, is that the stem cells in the cellular sheath surrounding the cartilage over here begin to produce a different cell type that differentiates into an osteoblast rather than a cartilage-forming cell. And we don't have a complete understanding of what controls the timing of that change. But once that change develops, the cells differentiate into mature functional osteoblasts, producing that thin layer of bone. Simultaneously, we're seeing changes in the cartilage, where the chondrocytes have become enlarged. They have taken in more water into their cytoplasm. Those cells are beginning to undergo the process of apoptosis. And if you look in the very center of this zone, you can see the chondrocytes lack nuclei. Some of them do. They're undergoing necrosis. And during that process of apoptosis, they are secreting cytokines that result in the chemotaxis of mesenchymal stem cells that will differentiate into endothelial cells that will produce blood vessels that begin to grow to that area of bone formation. Osteoblasts are very metabolically active. They need a high oxygen content. So for them to survive and continue to produce bone, they need that blood supply. Simultaneously, what's occurring, and that's one of the reasons why the cartilage matrix is darker, the matrix is mineralizing. The cytokines being released, we're getting growth of endothelial cells, which will provide a pathway for immature osteoclasts to come to the surface of the bone, which is mineralized, and the cartilage undergo multinucleation and begin to resorb that mineralized cartilage. So the next step would be osteoclasts boring their way through that envelope of bone into the mineralized cartilage. Osteoclasts can only resorb mineralized tissue, not just organic matrix.
So hyaline cartilage by itself wouldn't be resorbed by osteoclasts.
That's correct. It's like they have to have salt, which is the mineral, on the meat in order for them to be able to eat it.
That's a great analogy.
So the eventuality of this metatarsal is we would see evidence of osteoclastic activity boring a hole into this solid cylinder of cartilage and begin to resorb the cartilage towards either end of the bone. So I'm going to take you to an embryo that is a later stage. And we are looking at low power of a lower extremity. And the process has continued such that we can observe the following. All of the cartilage in the diaphysis, which is extending from the base of one growth plate to the base of the opposing growth plate is now composed completely of bone tissue. All of the cartilage has been resorbed by the osteoclasts. This process of the change in tissues from cartilage to bone is known as the process of enchondral ossification. And so the tissue manifestation of enchondral ossification is having mineralized cartilage being resorbed by osteoclasts, that some but not all of the cartilage is resorbed, leaving behind the struts of cartilage that act as a surface or a template for the deposition of newly formed bone by osteoblasts that arise from tissue-fixed mesenchymal stem cells in the marrow space. So I appreciate that it is all the tissue is not on the same plane, and I will point out the osteoblasts producing a thin layer of pink bone tissue which, overlies the cartilage core. So this process of destruction of one type of tissue, replacement by another, with cartilage being replaced by bone, that is the process of enchondral ossification. Bone formation occurs through one of two processes. The other type of bone formation is known as intramembranous ossification. And what intramembranous ossification is that the pre-existing tissue or model that will be replaced by bone is actually a membranous layer of what looks like fibrous tissue. And what that membranous layer is actually the periosteum. And in a growing embryo or fetus, it's a cellular periosteum, again, because they're rich in stem cells that differentiate into mature functional osteoblasts that deposit the bone in this anatomic location, forming the cortex. So all long bones of the body, all tubular bones of the body, form from both processes, enchondral ossification and intramembranous ossification. And it's very simplistic, but you could view as most bony trabeculae form from the process of enchondral ossification. Most cortices form from the process of intramembranous ossification. There are a few bones of the body, particularly lateral aspect of the clavicle, portions of the cranium, where there is no cartilage analoga, and the bone formation directly develops from this periosteal-like tissue rich in stem cells. So we go to stem cell osteoblast bone formation without the intervening model of cartilage. So let's look at the ends of the bones that are still composed of cartilage. We are looking at low power at what anatomic structure, Jared?
Looks like the synovial space
of the knee joint. Yeah, we're looking at the knee joint. We can see the patella is composed only of cartilage. The femoral condyles only of cartilage. Our tibial plateau, still the cartilage analoga of the bones. You can also see where the cruciate ligament is forming.
Amazing.
And let's see how good your anatomy is. Is that the anterior or posterior cruciate?
Oh, I have no idea.
Okay, so his homework assignment tonight is to understand what's the difference between the anterior and posterior cruciates and where are there
orthopedic surgeon.
Well, remember, orthopedic surgeons, the most sophisticated books they read are usually comic books. I'm going to get my ass kicked. And you're right, we do see the synovial space and all the loose connective tissue.
Wow, such a cool section.
Represents the loose connective tissue.
Much more vascular tissue in your connective tissue than there is in the cartilage.
That's correct.
There's no vascularity to that.
Yeah, so he brings up a very important point. We're looking at cartilage generally. Cartilage is avascular. during growth and development of the cartilage analoga, you will have some large vessels coursing through it. But an adult articular surface, our articular surfaces, no blood supply, no lymphatic supply, no nerve supply. So when we're damaging our chondrocytes, we don't sense it. And I always view it as the chondrocytes are like neurons. You are born with a set, you destroy them as you're an adolescent or an adult, they have a very limited capacity to replace themselves.
So this is why
And
the
that's
degenerative joint disease is
it's
so
so
problematic,
prevalent.
right?
Yes. I've traumatically affected my tibial plateau. I did that 25 years ago, and the orthopedic surgeon said, Rosenberg, you know, your medial femoral condyle has a 1 centimeter articular defect. You're going to be okay for a while, but you're going to be developing osteoarthrosis. And my knee hurts now. So I'm developing the symptoms of osteoarthrosis. But before I developed significant secondary changes, I had no sense of it. And again, it has to do with the fact no nerve supply. People make an analogous to like a quiet scream. Chondrocytes are screaming, help me.
But you can't hear it.
Nobody, it's not heard. So let's go back to the cartilage analoga. We can see there is a blood vessel in this proximal portion of the tibia, but largely the cartilage is avascular. It can live with much lower oxygen tension. So as we move towards the shaft of the bone, we can see a change in organization of chondrocytes. From randomly distributed, surrounded by relatively even amounts of matrix, we come to an area where we begin to see that chondrocytes are now lined in one another, forming columns. This is known as the zone of proliferation. Zone of proliferation refers to the fact that these chondrocytes, although relatively mature and differentiated, still maintain the biological capacity to undergo cell division. And as we look at this region of zone of proliferation, we have areas where chondrocytes are in the plane of focus, areas where there's only matrix. We're back again to areas where chondrocytes are lined in columns, and this reflects the relationship of these chondrocytes upon one another. They're like stack of plates forming a crude a triple helix or a helical structure, such that in this plane of section, these chondrocytes are in the plane, these chondrocytes are not, and so all we're seeing is matrix. These chondrocytes are, but notice we don't see the cell nuclei because the nuclei are in a deeper plane.
So they're all stacked together actually in much longer columns that just they spiral in and out of the section that we're looking at.
That's correct.
And so I thought that was great this morning how you explained that. I'd never thought of it in that light before.
And there's a very important genetic control of this cell activity, of going from a cell, if you will, what some people call a reserve chondrocyte or a resting chondrocyte, just making matrix, it becomes activated to undergo cell division, and then there's genetic control, controlling this organization of cells. Instead of what appears to be random distribution, that pattern is changed into one of a specific pattern of organization. And as we move closer and closer to the area of bone formation, we can see that several things are happening. The cells now are larger. There's smaller amounts of cartilaginous matrix in between the individual cells. So as the cells become large, that's the zone of hypertrophy. That's where, when you think of longitudinal growth of a long bone, some of it is accounted for by the increased numbers of cells that are forming in the zone of proliferation, but it's estimated that the majority of the growth of the long bone is accounted for by the increased overall size of the chondrocytes in the zone of hypertrophy. So the destination or the final change that will happen for the chondrocytes, which are now in the zone of hypertrophy, is that the intervening matrix will calcify. That calcification happens concurrently with necrosis of the chondrocytes, releasing cytokines, producing very vascular connective tissue at the very base of this cartilage, which is now we can call epiphyseal cartilage or the developing growth plate. And at the base of this cartilage is where we will see what looks like connective tissue with spindle cells. These spindle cells, in all likelihood, are stem cells that are going to give rise to mature osteoblasts that begin to produce bone on the surfaces of these residual struts of cartilage.
Amazing.
Once bone formation occurs, and we can identify that as a very thin and it's subtle pink layer of tissue. It forms what are called the very first bony trabeculae. Here is that thin seam of eosinophilic tissue, that's bone. And so this structure that looks like a sandwich, the bread being the thin layers of bone, the meat being the cartilage, that's the primary spongiosa. The fate of the primary spongiosa is that they undergo resorption by osteoclasts. And it's through this process of osteoclastic resorption of the mineralized cartilage of the primary spongiosa that we develop, if you will, a hollow medullary cavity that provides the space for the production and development of the hematopoietic marrow. So it's a beautiful example of enchondral ossification producing the medullary cavity. And so we're going to look at a more mature growth plate, and it's more mature in the following way. We are looking at the end of a long bone. It's the tibia. This is the tibial plateau that I'm showing, and different from the previous one, aside from just the size, in the center of the cartilage analog of the epiphysis, we have ongoing bone formation. And this will continue to occur in a centripetal fashion, such that eventually the entire epiphysis will be composed of bony trabeculae. And we will be left with the articular surface covered by articular cartilage, a bony epiphysis, and then a plate of cartilage, which is the growth plate that is between the epiphysis and the diaphysis. And here we see a well-formed growth plate with the reserve zone here in the center. As we move to the area of enchondral ossification, we can see that the chondrocytes are becoming aligned in columns. As we get closer to the area of bone formation, we can see that the chondrocytes are becoming enlarged, forming the zone of hypertrophy. The matrix has a change in color. Here is the zone of mineralization, and we have osteoclasts resorbing back some of the primary spongiosa, which you can see nicely, cartilage core covered by bone, covered by a prominent rim of osteoblasts. So people have done investigations showing how many new cells enter into the zone of hypertrophy every day of a human, how many cells in the zone of hypertrophy undergo necrosis and become a part of the zone of mineralization every day. And that process determines the overall size of the long bone. The genes that we inherit from our parents determines how many cell divisions these chondrocytes will undergo, will determine whether somebody is tall or has my height of like, unfortunately, I'm only 6'5", and I'm not 7'2". So it's the genes that we inherit play a very important role.
What age approximately is like at this level of development? What kind of age is this? A fetus that's in gestation, or a newborn baby?
No. So this is a fetus. So this is a fetus about 6 months of age.
And then how about the previous one you showed with the whole knee joint? What around?
Yeah. So that was about 4 months of age.
Okay. So it really changes a lot in just a short couple months.
Changes a lot in a very short period of time, and this will also, be a reference to how things rapidly change. Every year during the first decade of life, so 1 to 10 years old, everybody breaks down the entire skeleton and replaces it with one bigger. Wow. So there's tremendous amount of cell activity, tremendous amount of stem cell undergoing cell division, producing precursor cells, differentiation, differentiated cells, producing matrix.
That's amazing.
So it is amazing. It really is. And then once you get older, I'm 30 years old now, I turn over about 7 to 10% of my skeleton on an annual basis. So it takes a decade for me to replace my skeleton. That has implications with regards to bone turnover. When I have a molecule of my organic matrix, what might be a growth factor deposited by an osteoblast, when it sits in situ tip for 10 years, it becomes denatured, maybe a little over time. And when an osteoclast will come along, resorb the bone, release that growth factor, it's now a denatured growth factor, doesn't have that the same biological punch as a growth factor that's only been in the skeleton for maybe 6 months. That's some of the cause of osteoporosis of aging.
Wow.
Is that the molecules are present for longer periods of time that influences new osteoblastic activity, and the amounts of new bone formation occurs when we're 70 years old. There are a variety of diseases that can affect the skeleton during growth and development. And they can affect the skeleton of a variety of ways. Maybe I developed a mutation in my osteoblast, so they're not making good collagen 1. So the importance of type 1 collagen is it's the major structural protein of bone. Bone tissue is the strongest tissue of the body. It's about as strong as cast iron, but 1/3 of its weight, because most bones have a hollow cavity. What gives bone its strength is a combination of its unique composition. It's a biphasic tissue, organic, inorganic. The inorganic component is a mineral of bone. It's known as calcium hydroxyapatite. It's a way to look at it as I am wearing a leather jacket. The leather is made of organic molecules. This is the organic matrix of bone. Imagine if I were to impregnate it with cement analogous to the calcium hydroxyapatite. I have a relatively strong structure with some limited flexibility. That's what bone tissue is. So we can affect normal bone tissue by producing dysfunctional organic matrix, too little or abnormal type 1 collagen, and the name of disease where you have abnormal type 1 collagen that affects the skeleton is osteogenesis imperfecta. So the bones are fragile, prone to increased numbers of fracture. Or we can have diseases that affect the skeleton because maybe not the osteoblasts are dysfunctional, but the osteoclasts are. And if the osteoclasts are not functional, bone formation occurs, primary spongiosa develop, but they're not resorbed. And so we are looking in the medullary cavity of a fetus that died soon after birth, And in the medullary cavity, at this stage, there should be composed predominantly of 100% cellular hematopoietic marrow. And instead, the medullary cavity is filled largely by primary spongiosa because the osteoclasts are dysfunctional, can't resorb it, and it persists. This results in extramedullary hematopoiesis, where hematopoiesis will begin to develop within the liver and spleen. And so we can see here is our cartilage analog of the epiphysis. There's been a secondary center of ossification that has formed. This is the region of the growth plate where primary spongiosa is developing, and it is not being resorbed. And you can imagine what the x-ray would look like in a case like this. The cartilage is mineralized, the bone is mineralized, so the bone would show increased radiodensity on imaging studies. The other disorder that this slide nicely shows is the effects when you have abnormal mineralization of the skeleton during growth and development. We've already discussed the sequence of events that occur in the growth plate: reserve zone, zone of proliferation, hypertrophy, and mineralization. If the cartilage matrix does not mineralize, the cells in the zone of hypertrophy persist, and so that zone becomes markedly thickened. And a growth plate where there's a delay in mineralization and is thickened is the morphological expression of the disease that we call Rickets. So this patient has osteopetrosis, and when we look at low power, a very thickened growth plate composed predominantly of an abnormally thickened zone of hypertrophy. This patient has Rickets because the osteoclasts are dysfunctional. One of the major roles of osteoclasts is the bone resorption, where they release the calcium hydroxyapatite through the process of acidifying the tissue. Acid on mineralized bone is like water on salt. It dissolves the calcium hydroxyapatite and releasing the calcium to be utilized by all the different cells of the body. And one cell type or tissue that needs calcium is the cartilage in the growth plate. And if the cartilage is not mineralizing, it persists, producing the thickened growth plate. So in severe osteopetrosis, the developing embryo or fetus is not providing enough calcium for its growth plates, and so you get a combination of both osteopetrosis and secondary rickets. You would also expect, when you see rickets, that the state of mineralization of the cortex that is forming from the process of intramembranous ossification also to be undermineralized. And so you can get fractures at the base of the growth plate where you transition into two major different tissue types. So the two major different tissue types, solid cartilage and then the primary spongiosa, which are composed of struts of cartilage and bone. That is where there's greatest vulnerability to fractures. So in children with severe rickets, which is uncommon in the Western societies, they can get fractures at the base of the growth plates. So we're coming back now to different types of bone. We now have a good understanding of how bone tissue forms, either enchondral or intramembranous. The collagen, I'm going to take a step back and talk about bone tissue. It is a mixture of the organic matrix and calcium hydroxyapatite. The wet weight of bone, about 2/3 of it is accounted for by the calcium hydroxyapatite, about 1/3 by the organic matrix. When we're looking at a decalcified section, all we're seeing is the organic matrix. So we're seeing all the proteins. And so the major proteins we're seeing are type 1 collagen fibers, and then a variety of other non-collagenous proteins, growth factors, factors that are important in controlling regulation of mineralization of the tissue. There are many different types of cell receptors that are deposited in bone tissue. So an osteoblast remains attached to the bone forming surface. So when an osteoclast comes to start bone resorption, the cell membrane has receptors that bind to organic protein or molecules that have been deposited into the matrix by osteoblasts. The type 1 collagen molecules in bone tissue can be deposited in one of two fashions. They can be deposited in what we would say a random direction, or like a cloth, a weave, so they're going in every direction, and when they're present in that state, it's known as woven bone. The advantage of woven bone, it's made rapidly. An advantage is it resists forces equally regardless of the direction. So you can think of, in the setting of a fracture, early callus formation, the body is trying to generate an organic splint made of tissues. The first tissue it makes is woven bone to help provide support regardless of the direction of forces. The other architectural pattern is the collagen fibers are laid down in parallel array, and that's known as lamellar bone. Lamellar bone takes a longer period of time to deposit, and it's the strongest type of bone tissue in the body, and usually resists forces greatest from one direction. And each lamella of collagen has a slightly different orientation than the adjacent one, and thereby providing a lot of strength regardless of the direction it's coming from. The other characteristic of woven bone is it's more cellular. And the cells that we're seeing in lacunar spaces are osteocytes. Osteocytes tend to be oval cells. And with bone tissue, the long axis of the oval usually parallels the direction of the neighboring collagen fibers. So sometimes woven bone, they can look disorganized with regards to the cells because they're oriented in a variety of different directions. Woven bone is normal when bone formation is occurring rapidly during growth and development. Once the growth plates close at the end of puberty, woven bone should not be present in the body, and it's always pathological. And it doesn't necessarily indicate what the underlying etiology, but what it does indicate is the skeleton or the bone is responding to some type of force in which new bone needs to be made, and it needs to be made rapidly. When you do not see lamellae, you can generally make the assumption that the bone is woven. You can see in areas here next to a developing Resorption system. Notice that it's much less cellular. It's subtle, but you can see here striations. Those are the very first lamellae being formed. I'll contrast it to the neighboring woven bone. We don't see the striations. We can see many more osteocytes. So we're looking now at bone tissue from an adult rib. And we're looking at the cortex, and I think it's a nice example. You can see the lamellae of collagen fibers. Again, that's type 1 collagen. Look at the shape of the lacunar spaces. They're elongate. Look at the shape of the nuclei of the osteocytes, the shape of their cell. They are all parallel to the neighboring collagen fibers, and this is a nice classic example of lamellar bone. There are 4 types of lamellar bone in the body. 3 of them are located within the cortex. And to show you a good example of that, we're looking at a slide of bone tissue that is not stained with dyes, but is ground down and is very thin, so we can see several aspects. First of all, we can see the construction of the cortex, where we have the empty clear space that is the canal of the Resorption system, which normally would contain blood vessels and maybe a nerve. Adjacent to that are the surface osteoblasts that are adjacent to bone. Surrounding that are concentric layers of lamellar bone, within which are osteocytes. So the bullseye configuration of the concentric layers are known as concentric lamellar bone, only found in Resorption systems. If we go to high power, we can see the lacunar spaces for the osteocytes, and we can see the cell bodies of the osteocytes. And notice emanating from the cell bodies are numerous very thin, elongate dark structures. Those represent osteocytic cell processes. They are very analogous to a neuron. It's estimated that every osteocyte has about 100 osteocytic cell processes, such that each osteocyte is coming into direct communication with its neighboring osteocytes. And the cytoplasmic processes of one osteocyte, if you will, are holding the hand of a neighboring osteocyte, and that junction is a specialized junction. It's a gap junction. Gap junctions allow for direct transmission of small molecular weight molecules from one cell to another. It allows for direct transmission of electric potential on the cell membrane of one cell to another. And that way, the osteocytes are communicating with one another, communicating with the group of osteocytes within this Resorption system, and also are communicating with the surface osteoblasts. There are more osteocytes in bone tissue than any other cell type. And it's estimated that there are roughly at least 30 billion osteocytes. And when you think about of all the cytoplasmic processes, it's estimated there are about 32 trillion, osteocytic cell processes. To put that as a reference to neurons, it's estimated that there are about 96 trillion cytoplasmic processes and in interconnection. So osteocytes have tremendous amount of cell surface area.
So on H&E, we think of them as little cells in their own prison of bone, far from their neighbors, but in actuality, they're very, very interconnected community.
They are a web, forming a complex web for communication.
Amazing.
So the question is, what is the role of osteocytes? What do? They play a very important role in translating mechanical force into biological activity. Bone tissue is one of the few tissues of the body that can change its mass and structure in response to mechanical force. So when there is pressure on bone, there is micromotion of the fluid that bathes the osteocytic cell processes. They detect that. When there is pressure on bone, there's very, very small deformation of the osteocytic cell membrane. They detect that. They translate that into producing molecules, activating molecules like cyclic AMP that are activating, that goes from one cell to another to change an electric potential from one cell to another. Also, it produces cyclic AMP. So the message could go to the osteoblast: we're experiencing more mechanical stress. We need more bone tissue to be able to adequately resist it. Osteoblasts then produce more bone tissue. Signals are produced so the adjacent stem cells are receiving signals. We need more osteoblasts. Or conversely, if there's a diminution in the mechanical pressure being put on bone tissue, the osteocytes, hey, we don't need all this bone mass. And they shut down new bone formation by releasing molecules like sclerostin, which are inhibitory to bone formation. So they tell the surface osteoblasts, hey, stop forming bone. Or they may actually release molecules that say, let's get osteoclasts in here and resorb the bone. It is in excess. Both osteoblasts and osteocytes, aside from forming bone, aside from sensing their biomechanical environment, they're also endocrine cells. So what is their endocrine role? So osteocytes produce a molecule known as fibroblast growth factor 23. That might be familiar to you because what tumors produce fibroblast growth factor 23? A tumor that's known as
Phosphatory mesenchymal tumors.
mesenchymal tumors, yes. They have an activating mutation pumping out that protein. But what that protein does, it binds to the cells in the distal renal tubule and it helps control the secretion of potassium. So, phosphate. So, so again, I made a mistake. Fibroblast growth factor 23 controls phosphate secretion. So that's one endocrine function. The other endocrine function for blasts and osteocytes is they produce a molecule only made by them known as osteocalcin. How does osteocalcin play a role, an endocrine role is, though that molecule binds to the beta cells in the pancreas, stimulating them to release insulin. And in that way, the cells in bone play a very important role in energy metabolism. Osteocytes and osteoblasts also play a very important role in energy metabolism because they are involved in lipid metabolism and energy production. The other function for osteocalcin is during growth and development, it binds to the Leydig cells in the testis and it stimulates them to produce testosterone. So the endocrine function is it helps drive the developing embryo into a male phenotype and helps maintain male fertility throughout life. So again, in summary, the endocrine function of the cells of bone, phosphate secretion in the urine, glucose and lipid metabolism, and the development of male gender and maintenance of male fertility. So, going back to the 4 different types of lamellar bone, we have the concentric lamellae that form, here you can see, around the Haversian canal, the lamellae filling the spaces in between the Haversian systems. One ends here, another and one ends here, is known as the interstitial lamellae. The interstitial lamellae represent remnants of a previous Haversian system that's been partially destroyed by osteoclasts. So osteoclasts have come, destroyed most of the concentric lamellae, leaving behind some that act as the template for a new developing group of concentric lamellae. The last type of lamellae is known as the circumferential lamellae, and they are located just beneath the periosteum and along the endosteal surface adjacent to the medullary cavity. They form an inner and outer envelope of several layers thick of lamellar bone. So the cortex has concentric, interstitial, circumferential lamellae, and the 4th type of lamellar bone is trabecular lamellar bone, where generally the lamellae of collagen are parallel to the long axis of the trabecula. And so now we are looking at adult bone formed of lamellar bone tissue with a medullary cavity populated by hematopoietic marrow with a periosteum. And I will point out two layers of the periosteum. We have an outer layer, the fibrous layer, that forms a structural role, helps supporting the periosteum, and then the inner cambium layer of the periosteum. You can see from here to the bone-forming surface to the fibrous layer, it's more cellular. And it's within those cells that resides the mesenchymal stem cells that are going to give rise to osteoblasts to produce more bone. And so in a growing embryo, the periosteum is very prominent and has a relatively thick hypercellular cambium layer. This may be from a rib of a 50-year-old, and this degree of cellularity and the thickness of the cambium layer, to me, is an abnormality. There generally should be sort of thick layers of collagen right on the surface of the bone, because most of our bone-forming surfaces like this are covered by a quiescent layer of surface osteoblasts without that hypercellular zone. So to me, I'm seeing histologic evidence, oh, the bone needs more osteoblasts, so there's a thicker layer of the cambium region of the periosteum. And let's go to low power to try to understand, can we understand why? And as we move along the shaft of this bone, we can see that there's a change. The old cortex stopped right here. And we can see extending from the old cortex to now the periosteum, there appears to be interconnecting bony trabeculae. So there's new bone formation on the surface of the the cortex. And Jared, you are purported to have a good eye. Is this woven or lamellar bone?
It looks like woven bone.
Yeah, it's woven bone.
Fracture.
So this is increased amounts of woven bone being deposited on the cortex, and there's a hypothesis being put out there. Maybe this is fracture. If this is fracture, this is the body's attempt to heal the fracture, so this would be fracture callus. What about if I told you that in the medullary cavity there was a high-grade osteosarcoma? This could be maybe the reactive woven bone that the radiologist would say is the Codman's triangle that's forming at the periphery of the osteosarcoma. Or let's say I tell you that the bone is filled with an abscess. This is the periphery of the abscess. This technically would be considered the involucrum. The involucrum is the living envelope of new viable bone being deposited around the dead bone that has undergone necrosis secondary to infection. What about if I say there's a tumor and it looks like this? This could maybe be an example of a paraosteosarcoma. It's all woven bone but relatively well formed, so that's a possibility. Or maybe a benign bone-forming tumor like an osteoblastoma or an osteoid osteoma. It's important to remember that most bone-forming tumors, with some exception, the neoplastic bone, is woven in nature, trabecular in architecture. The exception is osteoma. So if you accept osteoma, which is a tumor that forms on the surface of cortex and is composed of cortical type bone, and it's usually a predominantly lamellar with some admixed woven bone, that's actually the most common primary benign bone tumor, because radiology studies have shown that about 2 to 3% of all adults have an osteoma. The vast majority are craniofacial in location. Occasionally you can get osteomas of the long bones, and when they're big, they open up the differential diagnosis. Are we dealing with a osteosarcoma? So getting back to this slide, let's try to identify why do we have a layer of woven bone on the surface. As we move along, we can see new tissue, different type of tissue. We can see it's blue, it's linear in distribution. That tissue is cartilage. It's hyaline cartilage undergoing enchondral ossification, recapitulating bone formation during the stage of embryogenesis. So bone tissue is one of the few tissues of the body that recapitulates its process of formation during growth and development in pathological conditions. So when we come all the way out here to the periosteum, we can see the cambium layer, woven bone formation. This is intramembranous ossification. So this bone that's forming on the cortex is forming from the combination of both enchondral and intramembranous. As we move towards the middle of the abnormality, we see a lot of cartilage. We can see it's linear, and as we enter into the medullary cavity, we can see a zigzag but linear configuration. So I'm going to go here. Let me put it in the field. This is the residual cortex. It abruptly stops. There is a gap, and the gap is filled by woven bone and fibrous tissue, and then we move to the other surface, and there's a sharp transition to the other side of the cortex. So this represents a fracture. This is the actual fracture line. Notice that the lacunar spaces are empty adjacent to the fracture line, because when blood loses its blood supply, it undergoes necrosis. So we have
That's a great example of woven bone and
Yeah.
lamellar bone.
and what he's indicating, this is the woven bone of the fracture callus, immediately adjacent to the focally necrotic lamellar bone of the cortex. Look at the surface of that fractured cortex. It's not a sharp line like you would expect it, which in areas maybe it is. There are these little scallops. Those scallops represent areas where osteoclasts once were, that are begin to resorb back the dead bone. The goal is the bone wants to get rid of whatever is dead, replace it with living, viable bone tissue. And in the early stages, the living, viable bone tissue is woven bone. And you can see that that is even being remodeled by osteoclasts. Because how do you go from woven to lamellar bone? It's not magic like redistribution of the collagen fibers into lamellar bone. All of that woven bone will be resorbed by osteoclasts. Osteoblasts will then deposit lamellar bone.
By making a Haversian system.
Haversians, first you will get structures that look like trabeculae. They become thicker. You get osteoclasts growing in, resorbing them out, creating the canal for the Haversian system.
So that's how the lamellae get laid down in the lamellar bone. So basically this is a template. The woven bone is a template to build a new...
And to provide immediate or early structural support. The same thing with cartilage. It's also forming some structural support. You can see how it's undergoing enchondral ossification. So in this little high power field, we have both ongoing enchondral ossification here, intramembranous ossification here, forming the early stages of fracture callus, and you can see how that process goes through the medullary cavity. Notice also how in the medullary cavity, much of the bone formation is occurring through intramembranous ossification, relatively small amounts of cartilage. Because it's very vascular, and cartilage doesn't like high oxygen tension levels. So we're seeing fracture callus spanning the two ends of the medullary cavity, and we see fracture callus spanning the two ends of the cortex that's been disrupted. And so over a period of time, the fate of this tissue, the cartilage will undergo complete enchondral ossification. All the woven bone will be resorbed and be replaced by lamellar bone. So eventually, maybe 2 years from now, if you were to take this rib out and look at it under the microscope, there would be zero histologic evidence that was ever fractured. Unlike any other organ system that forms scars. You get, like skin, you cut your skin and dermis, that's a permanent injury. It never repairs to its normal state because of the deposition of the collagen fibers, which are usually parallel to the surface of the skin. So that's another relatively unique attribute of the skeleton, and it can do that because it harnesses those embryological processes that were responsible for its formation. So, let's talk about some other conditions that affect cell activity, and we will bring it to a close in a very short period of time. This is a needle biopsy from a vertebral body, and I will point out some findings here. We have a trabeculum of lamellar bone. It is no longer surrounded by fatty or hematopoietic marrow. It is covered by metabolically active osteoblasts and surrounded by a sheath of connective tissue. Attached to it are interconnecting trabeculae of woven bone. And as we go to low power, we can see this network of woven bone trabeculae are connecting one lamellar trabeculum to another. This is an example of a compression fracture from an older woman who is osteoporotic. So these bony trabeculae are thin. They have broken, elicited, or resulting in fracture, eliciting fracture callus, which is predominantly producing bone via intramembranous ossification. And a lot of it, as in Western societies, we're living longer, more patients are becoming osteoporotic, so osteoporosis is a significant health problem, and this is the histological manifestation of that. In the United States, it's estimated that every woman, once they reach the age of 70 to 80, 50% have some type of pathological osteoporotic fracture. It could be like this in the spine. It could be a femoral neck fracture, a fracture in the distal radius. Why do we have this tissue? Because they're trying to provide increased structure to that vertebral body. They remove a core of tissue, providing a pathway to put in a needle, and they are injecting bone cement into the spine to help prevent the accrual of additional fractures occurring over time. One other disorder manifests by bone cell activity. We are now looking at actually bony trabeculae, and they are thick. And we can see that many of them have a nice lamellar pattern. Notice on this, look at the surfaces of the bony trabeculae. Generally, bony trabeculae should be nice and smooth like a tabletop. When you look at all the surfaces of these bony trabeculae, they're scalloped. Anytime you see scalping, it means osteoclastic activity. We have an example of a very large osteoclast with many nuclei. Generally, a normal osteoclast has at maximum 12 nuclei. So this is upper limit of normal or abnormal. We talked about lamellar bone. Generally, units of lamellar bone are deposited roughly parallel to one another, and the units of lamellar bone are defined by a layer of mucopolysaccharides, which manifests as a dark line, and it's known as the cement line. So the cement line defines units of lamellae that were deposited by one group of osteoblasts. So it's like bricklayers. I build a wall that's maybe three feet high of bricks, and then I cover that with straw, and then another group of bricklayers come and deposit bricks on top of that layer of straw. That straw is analogous to the cement line of which group of osteoblasts made the bone. And generally, the cement lines parallel one another. In this tissue, I would argue the cement lines are going in random directions, forming units of lamellar bone in a simplistic way, sort of mimic the shape of pieces of a puzzle in a jigsaw puzzle. Irregular shape. And that irregular shape, again, is being highlighted by the cement lines. And what we're looking at is an example of what disease?
Paget's disease of bone.
Yeah, this is Paget's disease of bone, very good. And it's the active stage of Paget's because there's ongoing osteoclastic and osteoblastic activity. Yeah. Notice on one surface here, we have class. One surface here, we have blast. We have a beautiful example of the mosaic pattern of lamellar bone that's diagnostic of Paget's disease. Osteoclasts and osteoblasts, they are coupled cells. Coupled because as osteoclasts are resorbing bone, they are releasing growth factors that stimulate the fixed mesenchymal stem cells that produce osteoblasts. Osteoblasts control osteoclastic activity because they secrete molecules that stimulate the formation of class and stimulate their activity, molecules such as rank ligand. And so the blasts are forming the class, and as bone tissue is being resorbed, they're releasing the signaling molecules to say, whatever bone's being resorbed, we need to have it replaced by blasts. So the current understanding is Paget's disease is a slow viral infection. That maybe the osteoblast is the first cell to be infected, depositing units of lamellar bone, not according to the mechanical forces it's being subjected to. They're now the viral genome is screwing up the osteoblast. They're depositing the lamellae in random arrangement, forming these irregular units. The osteoblasts infect the osteoclast, resulting in their increased number of formation and activity and increased numbers of nuclei. So, beautiful example of Paget's active stage of Paget's disease of bone, highlighting how even in a pathological process, bone formation is coupled to bone resorption, and vice versa.
This is fantastic. Amazing from start to all the way up through birth and beyond, and then all of the different ways that deranging this finely tuned system can really cause problems for us and cause disease, right?
That's correct. So when you look at Jared, you can now understand how he's become what he has become.
Thank you, Andrew, so much. This has been wonderful. I learned so much. I think all of us did, and I'm sure that people around the world on YouTube will appreciate this very much. Thanks for your time.
Okay, thank you.